Randy and I have been doing this podcast for about a year now, and I can't tell you how many times people kind of said what you just said. Hey, we're experienced. We know this. We know the system, and we still get lost in the system.
I can't tell you how many times in my cancer journey and other things I've been on, I've been lost. And I'm like, I know this stuff and I know who to talk to. I know what to say. I know how to push. But like, I could not get to the person who was making that decision for my prior authorization. That is ridiculous. That should not be the case. And I believe prior authorizations are right, but there should be a process that involves the patient, not that sidelines the patient.
So welcome back, everyone, to the Only Healthcare podcast. As part of our risk series, today's conversation dives into one of the most pressing and complex issues facing employer-sponsored healthcare, and that's managing risk and benefit design, particularly around rare disease and high-cost novel therapies. We're really fortunate today to be joined by Tom Sondergeld, who's a managing partner of TS Consulting Group that has over 30 years in healthcare benefit consulting. He's also been a senior advisor to McKinsey & Company. Tom is not only a national leader in benefit design and strategy, but is a catalyst for real innovation in high-cost care delivery and financial protection for employers. So Tom, welcome. Thank you for joining us, and give us a little bit of background on yourself.
Sure. I'll add to a little bit of what you said, but I think most of my experience was sitting in the benefit chair trying to make decisions for large companies like Aon, Hewitt, and Walgreens, right? For, 25, 30 years. Started out in healthcare. I was a respiratory therapist. So kind of know the healthcare background. My dad's a pharmacist. My mom's a nurse, kind of healthcare in the blood. So, just a lot of healthcare knowledge that I've gained over the years. My experience with McKinsey and others just really helped quite a bit. And then I had a little bit of stint with the PBM. So I know all the angles and kind of have developed a pretty interesting approach to, help employers, payers, others look at healthcare costs.
So I guess we'll sort of dive into a couple different segments of this. One is really, the first thing is really talking about framing the current landscape, right? So there's so much innovation happening and there's so many advancements in treatment, but there's also managing that risk. So one of the things we wanted to ask you is, how do rare diseases and novel therapies like cell and gene therapy change the game for employers as payers?
Yeah, I think it's going to be quite a ride the next couple of years. It started, there's like 30 or so cell and gene therapies that have been approved by the FDA. There's more coming. There's a massive amount of ultra-high-cost therapies coming to the market, 3,700 or so in the next couple of years. And I think that employers are going to get hit with costs higher than they've ever seen for one case, right? While it may be curative, and I say curative in quotes because nobody really knows yet, hasn't been out long enough. While it's curative and it could have a lot of value for employers, and employees, it's going to cost, millions of dollars for one case. And I know in the past when we've been hit, even at large organizations with large costs all at once, I'm in the CFO's office, right, trying to explain what happened and how did this happen. So I think employers have to be prepared for what's coming. I think there have to be some really novel approaches beyond risk pools that kind of just help employers deal with this, maybe regulatory, maybe cost solutions that bring employers together into a pool that can buy drugs together in maybe like a health purchasing alliance. So I think there's going to have to be some different innovation that's going to break some of the bonds that are in place today, because as we know, one employer is one employer, right? And I think there's going to need to be a more massive look across the spectrum.
And you kind of mentioned the PBMs in your experience there. Do you think they're part of that answer, or do you see more GPO type?
Yeah, it's interesting because the landscape over the last 5 to 10 years has changed dramatically, right? All the verticals in healthcare, most of the large players, the large health insurers have a PBM. And so I'm sure in the background, even if it's not the PBM that's buying the drug, and it's the health plan buying the drug through the medical services and maybe through the provider pool, I still think they're going to get involved. Maybe not directly. And certainly their GPOs are going to be a big part of it. I just don't know about the navigation because it is through the medical plan. It's a therapy more than it is a drug. And so I don't know that it's going to have those formulary kind of flavors to them. And I think decisions are going to have to be made like maybe one by one on how some of these things are handled for employers. So it's, I don't know, PBMs might have a place in it, but they may not. I'm sure given the way they look for margin, they're going to try, but I don't know. You'll see.
Is there any, are there current shifts that you're seeing in utilization trends and cost distribution among especially the smaller employer populations?
Yeah, I think it's hitting them the most, right? Because a $1 billion plan, it's easy to hide 4 million bucks, right? Unfortunately, but in a small pool where you have maybe $2 million, $4 million plan, you hit one $4 million bump, you doubled your cost just in one bump in like July, right? The worst time ever to have a bump after you've already built your accruals for the next year. So I think for mid-sized to small employers, it has a dramatic impact, right? I think large employers, they'll be able to take most of it in and deal with it. It's really not very fair distribution, but that's why I think there needs to be a better distribution of this pool because it really unfavors the mid-sized to small size employer. And once you pay, you're going to attract more people, right? And who need the medication or the therapy. And so I just think it's a domino effect.
And to that end, what do you see as the biggest, risk on the employer? Is it the financial or the reputational risk?
I think it's both. I think, if you say you're not going to cover it, think about that reputation, right? Just think about a large employer who just says, you know what, we're not going to cover that. And it's curative for MS or something. Oh my goodness, that the MS community will come down on you, right? I think it's reputational, but it's also cost. I mean, these things are even for a large employer, like when I had a large hemophilia claim come through in the past at Walgreens, it caught our attention. Or a premature baby that cost $2 million, or a lung transplant, right? They all flag, right? Because they're a single big bump. They kind of maybe double your monthly allocation. And so, because trend is really hard to manage monthly, volatility in self-insured employers still is going to be a massive impact. So I think it's both. And I think that has to be really looked at carefully, because you don't want to have a CFO say yes to something and then be mad at you or CEO mad at you because you paid $5 million for some curative therapy. It's a tough conversation.
Are there solutions that exist right now that help mitigate this?
I think they're developing. I think what we're going to see is that right now there's a distance between the pharma manufacturer who's doing this therapy and providing the therapy for the most part, especially in some of these localized centers, and then the employer, right? Who they never talk. I mean, I don't think in all of my time, well, maybe at Walgreens aside, because that was different. And most of my time, I hardly ever talked to a pharma manufacturer. It was through a PBM, it was through a medical plan, it was through some other way, or carrier or TPA. Very rarely did I have that conversation. And if I did, it wasn't about cost or therapy, it was about some other thing. And so now I think that's going to have to happen, right? And I'm starting to see it. I'm starting to see pharma manufacturers reach out to the employer groups and want to do stuff together, risk pools or education or just navigation, right? I think it's just this stuff is tricky, right? There's a whole process that you have to follow to get into these therapies, even once they're approved, right? And so I think that there's a need for something that's going to happen there, but I don't know what it is yet. But I am seeing it. I'm seeing it pop up quite a bit.
Are there compliance risks that exist under ERISA when these drugs are being added to either the medical benefit or the formulary without like the real full like P&T rigor that they're supposed to come with?
Yeah, I mean, there could be. I mean, there's a lot of challenge to fiduciary risk right now, right? Especially in the pharmacy area or the drug area. And I think we have to be really careful as employers and really be sure that with our ERISA attorney, who may be more conservative, which can pull us back a little bit, is not a bad idea, that we look at all the risk, because there's likely some risk, whether you say yes or no. If you say yes and then you don't guide the person correctly through the therapy, you could be at risk. If you say no and you should say yes, for some reason it gets covered under a regulation, or the mass part of your industry is covering it and you're not, you could be flagged for risks violations. So I just think you have to be really careful in this space. I'm not an attorney, but I know my attorney friends would say, hey, be careful.
Yeah, so risk and financial responsibility. Which one do you want?
Well, and I think it's going to navigate to a lot more conversations with senior executives who haven't had benefit discussions in the past, unless something flagged. Now it's going to have to be a wider conversation. Like, what do we do? Where are we going? What's going to be our pathway? How do we look at this? Is there a different way for us to pool? CFOs are very good at this stuff. Maybe it's time to really bring procurement and CFOs closer to us as benefits experts, to kind of lean in on breadth of expertise in order to kind of manage some of this stuff, because I think it's going to get to be really challenging.
When you look at the large employers under ERISA, obviously is different from the small to mid-size that maybe are still fully funded, just purchasing health insurance coverage. But if we just look at the larger plans for the moment, are most of those large size employers aware of their exposure when it comes to novel therapy under ERISA?
I'd be surprised if 40, 50% of them know at all. I think some of them are becoming aware. They're hearing about it, right? At conferences, it's coming up. At certain coalitions or organizations, they're talking about it. But I don't think they've actually looked at the risk pool that they carry to say, hey, look, you have this massive population. You're likely to have 6 of these people that could need these high cost therapies. 6 times 4 is $24 million. That's harder to hide. And I don't think they know that exposure because they haven't done any predictive analytics. They haven't looked at their population that way. They've looked at it different ways, but not this way. And this is going to take a lot of more predictability and using AI tools that are coming out like crazy.
Kind of expanding on that, how can employers do a better job of looking at this risk and the overall process around benefit development and then the execution of it, along with the duty of care from an ERISA perspective with these higher cost therapies?
Yeah, I think there's about 3 or 4 things that I like 3 or 4 things that employers could do. I think one, become educated, right? Know what is coming down the pipeline. Connect to coalitions, connect to organizations, connect to experts who understand the pathway that's coming. Connect to pharma. Pharma manufacturers know, especially the cell and gene ones, Johnson and Johnson and others, Novartis, that are really in this play, right? That are getting close to either buying a small entity that's developing these therapies or whatever. Two, I think it's really important to start having the conversation with your senior leadership. I think you better start pulling them in closer. And once you're educated, know how to bring that education to your leadership. And then 3, prepare your answers. What are you going to say before it happens, right? I don't think you want to have an after conversation about a $5 or $7 million charge, right? You want to have it before, and you want to have a prepared answer that is, yes, we're going to cover this. No, we're not going to cover it. Yes, we're going to get into a risk pool. No, we're not going to get. I think you kind of need to explore the financial opportunities that are developing out there, because there are some that could help employers, and then lean into those quite a bit, because I think we're going to need to kind of partner together as employers more than we ever have.
Beyond just the pipeline, I just wanted to throw something in that's relatively current with all the activities in Washington, D.C., not just executive orders from President Trump, but also Congress and the big, beautiful bill, the BBB. How's that going to affect or impact what we're talking about here today?
Yeah, I mean, if you follow the money, right, and if truly there's going to be a massive reduction of Medicare and Medicaid costs in this and eligibility in this country, then that's only going to push on the cost of healthcare in our country. And hospitals and providers are going to have to provide more free care. And if they do provide more free care or emergent care, then they're only going to ask for more from the people who pay. And the people who pay are employers. Commercial market pays, right? And so they're going to lean on us. And if we're paying 200, 300% of Medicare now, there's a likelihood we could be paying 400, 500, 600% of Medicare in the future for some of these things. And we have to be prepared for that as well. I think the bill at the law, which is law now, and a couple other things that they're considering that are coming soon in some consolidation bills are kind of going to set the trend for employers to be they need to be aware of some of the cost trends that are coming that could put us into the double digits going forward in the future, right, for a while. And I think it's going to be hard to address because we can't keep pushing anymore to families, because we have boundaries by the Affordable Care Act and other things and other regulation. So we have to kind of find a way to cost manage this stuff. And so I just think that employers have to be ready to start talking together. And I do think that these costs are going to hit us pretty hard in the next couple of years, all the way through 2030, when some of these things start to sunset.
So are there current innovations in plan design that you've seen that can provide the care that's needed, but also prevent those major catastrophic claims from hitting the bottom line of that company?
There's talk of multi-employer risk pools and navigation and conversations with purchasing organizations like health purchasing alliances that kind of would buy these groups together and maybe put some stop loss or risk aversion in that creative care. So I think employers have to look for that. I think some plan designs, reference-based pricing is a bad word from 20 years ago, but has reformed itself and kind of come into the 2025 era. And I think it's a very valuable solution that could help with some of this negotiating prices and getting prices to a good area. It's not for everybody, but I do think it's a way to kind of like have that conversation that never happens between an employer and a health hospital or a provider. So I think that those are two really good ones, but I think watch out for some of the financial models that are going to come out from some of the pharma companies that I think are going to help address it. I think they're aware that this is happening right now. A lot of the therapies are being developed by a lot of small biopharma companies that the big ones are eventually going to just swallow up or they'll disappear. And so once that happens, I think you'll start to see movement on the pharma side.
I think with the CAA though, you've seen like the publication of these machine readable claims files. You can actually see the claims that are being paid, and not necessarily on the drug side, but on the medical side. And there's a lot of companies who've created point solutions to bring that to light. Have you seen anything with that? Any kind of momentum?
Yeah, they're really leaning in and talking about the whole person, which it really is about whole person care, right? A lot of care is about behavior change, right? Even if you have cancer, you have to change your behavior because you now have to get care, you have to get chemo, you might have to take drugs. And that behavior change is not overnight. It just doesn't happen because you put in a point solution, right? And so I think point solutions have kind of come together a little better to bring a holistic approach, mental health, behavior change, the change on the actual therapy or the condition they're trying to control, and then the outcome of the individual. I think those are all kind of pulling through some value-based care that's coming out that's pretty exciting, and it grows almost every week. I think they're coming together to try to provide solutions, together. You look at Teladoc and Livongo, who came together to kind of like bring all of it in a more holistic approach. I think that's the right way to go.
And then I guess what kind of role can these vendors play? Like I think we're referring to like some of these coalitions, like Midwest Business Group on Health, in supporting the overall decision making to partner with these solutions, but also to redesign their benefits.
Yeah, I think the purchasing groups, the certain, Midwest Business Group has a purchasing arm. The Midwest Coalition of Healthcare has a purchasing arm. A few other coalitions around the country, IBI, I think, has a purchasing arm. That when they have those, I think they should be leaning into those and bringing solutions to the employer market, maybe at a discount or at a group rate that helps smaller employers be able to afford some of this stuff, so that it can be effective. Like, I look at GLP-1. It's only going to continue to grow. I don't think it's going to go away. And so you have to manage it. You can't just give somebody a GLP-1, right, to control their behavior. You have to give them a GLP-1 with care, right? And so there are good providers out there that do that. I think if you look across all the different disease states, there's decent providers that are kind of looking at the right way to bring care to the member and change behavior. The goal should not be to be on drugs every day unless you really need it, right? If you're diabetic, sure, that's a different story. It's a longer tail. But if you're trying to fight obesity or lack of exercise because you have bad joints, then look at your whole person, right? Don't just give somebody a GLP-1 and not give them like a hinge who can help with or Sword, who can help with the physical therapy, or give them a mental health provider that can help kind of bring the whole picture together. You can't look at it just as one strata. You have to kind of look at it across the strata and really care for the individual, so that if the goal is to get off the drug, they have the tools to get off the drug.
What might be either one of the most effective or the smartest way for employers to handle coverage for these expensive therapies? They're all expensive, and the conditions may be only a handful of patients in the country to maybe just a few hundred or 1,000.
Yeah, so I think you kind of have to take a different approach than we've taken before. We've taken kind of a peanut butter approach where it's just like, hey, I'm going to have this formulary and I'm going to cover these drugs and I'm going to put in prior authorizations and step therapy. And those all are not going to work for these high cost drugs. I think we have to look at partnered solutions, and we have to bring a value-based benefit design that allows the person to get the therapy, but they also have to participate in these partner therapies. So if you're going to get a very high cost cell gene therapy for cancer care, then you should be paired with a cancer care program, right? So that not only are you getting the navigation for that therapy, you're also getting the holistic approach to your cancer care that you need to have, because it's a mind-blowing experience, and you don't want to take the person out of work. So I think you kind of have to look at that value-based benefit design to say, I'm going to connect you with this, and that's how you're going to get this. Not just you get this, right? It can't just be a carte blanche. You have to kind of put in some things to say control. And so I think that will push the EEOC and others to kind of back off of their condition management, HIPAA privacy kind of thing, and unfairness around ADA disabilities, to kind of like say, hey, look, we understand people have disabilities, but you're trying to treat the disability. And so if you are, let's look at a holistic way to kind of deal with that, rather than put legislation and regulation in place that backs into the corner, which is where we're at right now, because it makes it very hard to put in value-based care as an employer, because you get in trouble with the disability rules. So I think we have to kind of like try to form some of that conversation so that these connected value-based benefit designs can be put in place without fear of doing it for the detriment of the individual. It's really to benefit them and make them more healthy.
How do we prevent the patient from getting caught up in the system that denies the high cost out of fear while still protecting the employer, right? Like, to make sure they don't go out of business.
Yeah, what worries me is the way drugs are taken on and off formularies, and the decision is really out of the hands of some employers to make that decision. It's by the middleman, and so I think we have to be a lot more involved. I think we have to be a lot more knowledgeable. I think we have to push on some of these solutions, but I also think we have to prepare for the patient, right? We have to help that. It has to be from a patient back kind of approach and say, what's the patient experience and how can we improve it, right? So they're not lost. I'll tell you, I tried to get a prior authorization the last 4 days. No one would tell me why I was in a prior authorization hole. They just said, you have to wait 2 days. I'm like, but what am I waiting for? What do you need? I can help you. Nobody would help me. And if we don't understand the implications that puts on a patient, it is a lot of pressure to say, I may not get my drug because of this prior authorization. It's ridiculous. And I'm like, I know the system. Can you imagine a healthcare worker on a maintenance line whose wife is sick with cancer? Not only are they worried about when they're away from home, now their wife is sick with kids at home and they have no support. We have to kind of think about the patient experience and really put in designs and programs that really help them not get lost. Lean in on navigation, lean in on support, lean in on those things that can get together, buy through coalitions, because when somebody gets lost, they just get frustrated and then they don't come to work. And that's not what we want as an employer. We want them to be engaged and productive, whether they have someone at home or they're dealing with their own sickness. So I think we really have to look from the patient back.
Yeah, I mean, Randy and I have been doing this podcast for about a year now, and I can't tell you how many times people kind of said what you just said. Hey, we're experienced. We know this. We know the system, and we still get lost in the system.
I can't tell you how many times in my cancer journey and other things I've been on, I've been lost. And I'm like, I know this stuff and I know who to talk to. I know what to say. I know how to push. But like, I could not get to the person who was making that decision for my prior authorization. That is ridiculous. That should not be the case. And I believe prioritizations are right, but there should be a process that involves the patient, not that sidelines the patient. And so I get very frustrated when these things happen. I've had bills that have come my way that I should never have had to pay. And I'm like, well, and I've talked to the billing person and no one can explain this stuff. And so there is like this magical thing that some navigators just understand about the system, and having a third party that isn't kind of in the way and isn't invested really helps kind of push through some of the milieu. It's absolutely right that we should be thinking about the patient, because in the end, patient suffers, we all suffer, right? In the end, more cost, more trouble, less engagement. Oh, they leave the organization. That's even worse.
And just rounding that out on the patient side, what role can partnerships between the manufacturers, providers, and employers play?
We need to come closer together. The middleman, middle woman, middle person, that company has always been in the way, right? No offense. It's just how our system was set up. There's a provider, there's a payer, there's an end payer and the real payer. And there isn't a conversation between the two. When there are, I look at organizations like Boeing and Caterpillar who are having those direct conversations, and they're able to save demonstratively and continue to have successful coverage for their members. And so I just think we have to kind of innovate more and bring those conversations closer together to the actual payer. The employer in a self-insured world is the payer, right? Even in a fully insured world, they're still the payer because they're carrying the secondary risk, right? So I just think the employer is the payer. Bring the conversation closer together for the providers and for the pharma manufacturers, because that's where the conversation needs to happen to be more effective.
So along that line, looking at it, sitting in an employer's chair at any level you want to pick, C-suite, HR, whatever, how are these employers going to be navigating that emotional line between supporting their plan members, the patients who are their employees, and this financial stewardship issue that we've been talking about? Not only ERISA, but even if you're just buying a plan.
Some of it is, unfortunately, the emotion may help or hurt, right? And sometimes you have to evacuate the emotion in order to get the right decision, but sometimes you have to let the emotion in so that you can get to the right decision. And I think it's deciding what is right for your organization, standing behind it always, not allowing approvals outside of your final decision, because when you do that and you show favorability or not favorability, it really damages your reputation, but it also gets heard. Believe me, they hear about it. Your employees hear about it. So stick by your guns when you make a decision. If you say you're not going to cover GLP-1 for weight loss, then don't cover it for weight loss, period. And stick by your gun and have a rationale for why it, and have a patient journey that supplies around it, right? I think you have to make logical decisions, but also informed decisions with the right people. So make sure you're connected medically, make sure you're connected to ERISA attorneys, make sure you're connected to pharma who can help you make some of these decisions. Because if you don't, then I think you're missing out on making the right decision, which could be cover it, but do these things to make sure it's covered right. And that, rather than bringing the emotion into it where, gosh, it'd be awesome to cover all this stuff all the time. You can't. Sometimes you have to put limitations there. We have deductibles for a reason. You can't say we're not going to have a deductible half the time. You have to keep it in place. And so I just think the same decision logic has to sit on the deciding of whether or not you're going to cover something.
So, looking forward, being collaborative, innovative, and risk sharing, what any disruptive models you see right now happening with PBM reform, direct contracting, value guarantees that show some level of promise that you're seeing right now?
Yeah, I'm seeing some manufacturer warranties that are showing some good promise. I think some of them that I've looked at have really been well designed and well thought through, even if the employee leaves the employer, but had coverage for one of these very high cost therapies and it was paid for. The warranty carries forward with that company and that person. And so I think they've really thought through some of the machinations of these very long term treatments that I think will help a lot. I think it's good to see that. I haven't seen that before. I think that's amazing. I think there are some third-party players that are coming to market that are looking at ways to pool, right? Ways, not maybe with maybe a risk pool, but with, hey, come in, buy our service. We'll cover you stop loss for these things. We'll do a buying agreement. We'll go, we'll help your PBM or your medical plan kind of navigate this solution, and we'll navigate the member through it, right? There are some that are doing that. I think that's really going to help a lot, because while the quantums and the accolades or whatever they're transparent now, while they all do that navigation stuff, they don't do this navigation. This navigation is unique and special. And some, great websites have come up from some of the pharma manufacturers to kind of describe it. I think we have to kind of lean into some of that. And then the third thing I've seen is there are some really interesting financial models that are being considered. There have been a few that have written up by Deloitte, and I think they're very interesting. I don't know that they're going to turn into something, but I do think that multiple purchasing groups, looking at discounts, looking at ways to maybe put some kind of like buying currency, buying against these things into a pool, and then when you have to use it, you draw down from the resource. And then I think there's some regulatory concerns that people are going to have to get addressed at the higher level. I don't know if it's this administration that'll do it. They could, but it could be interesting to see something that comes out that says, hey, look, we understand these drugs are really expensive. We're going to create a pool, and here it is, and this is how you access it because of the Affordable Care Act. That would be a long long gameplay. It's been hypothesized, but I do think it could be really innovative to do that. But I haven't seen any real plan designs that kind of address this problem, and I haven't seen the carriers come up with anything yet. But I think once 3 or 4 or 5 claims hit, they'll start bringing to the table.
I kind of come from the manufacturing side, and market access, affordability, and the rebates. Say what you will, the rebates have gone from very modest to significant. Like, if you even want to be on our formulary, I need 80% off. And yeah, and so do you think that's imploding? Do you think that's going to move to a more of a net cost model?
I think it'll have to. It can't keep going. It just can't. It's not sustainable. Efficacy questions come into play, right? Our fiduciary responsibility in the end is, if we make a decision to go onto a formulary and that formulary does not contain a more efficacious drug, a member could flag us, right? And our risk is high. And so I think we have to kind of look toward the cost plus models, which all of them have now created. The big 4 PBMs have all created cost plus models. I don't know that their definition of rebates have changed, which I think is part of the problem, is they hide rebates by different definitions. And I think even in the cost plus model, you're still doing it. But there are some great solutions out there that do cost plus or do some other version of cost plus based on some, market leading cost measures. And so NADAC and others, I just think there's some interesting stuff coming out of the market that will kind of lower that pressure, remove rebates, and kind of create a more market-friendly environment where we're not paying through the nose. But I'll tell you, it's just as bad on the medical side, because they do the same thing to providers and hospitals, and we don't even know it because we don't get to see those contracts. And they have steerage in those contracts that make it hard for them to steer people away from the higher cost places. And so it's all kind of got to kind of come out and get talked about more openly, because in the end, it impacts the care we're providing and the costs that we have to pay.
Is there anything an employer can do to lead the change rather than wait for the government or some kind of lawsuit to make them?
I would like the jumbo and large employers to kind of like take some lead here, not wait for someone to jump. That everybody waited way too long for the private exchange. It's why it fell apart, because there were too many people waited and the risk pool wasn't good enough. You need a big risk pool. That's why the ACA for a while was doing okay. Now it's going to collapse. And so I think it's a problem when we don't get the right risk pool. So I think the large employers need to kind of come together with the jumbos and kind of say, hey, look, here are the issues. We're educated. We know the problem. We want to talk to pharma. We want to talk to providers. We want to talk to the carriers or TPAs. We want to have these conversations that are very open. And we're demanding that there be some regulatory control here, that because these costs, while maybe 1 or 2 in a population, can still be tremendous. And so I think the large employers are just going to have to, if they don't come together in a coalition, they have to come together as a voice, right? And they have to all be educated, and they all have to follow a similar path so that we can all work through this together, because I don't think we're going to be able to work through it as one employer. While the jumbos may be able to do it themselves, I think they need to kind of look at their bigger responsibility to the whole and lean in to support those mid-sized to small employers who are not going to be able to do this. They're just not. And that's going to be tremendous pressure back on the large employers, because those people that can't get it at the small employers are going to seek out employment at the large employers and get the coverage. And then you're going to have an explosion within the population, and it's not going to be 2 or 3, it'll be 15 or 20. And then multiply that, you're now in a bad place. And so I think we have to kind of look at this as a together problem rather than an individual. When we've looked at like populations and data, I think you got to get to, close to 2 or 3 million before you start to really see it in the populations. And so that's why I'm saying the large and jumbos need to get together. I don't think, Walmart, probably the closest one that comes to 1 million members, and they probably could do it alone. But if they come with Boeing, and if they come with Walgreens, and if they come with CVS, and if they come with a bunch of other players, and maybe some healthcare plans that are in there that have employees too, and they all think together, I think they'll have a better answer than if I'm 1 million and go after it. If I'm 10 million, like the HTA, the Health Transformation Alliance, would be amazing if they would take this on with their 7 or 12 million lives that they have. It would be awesome, because that's the perfect pool. They've all come together to try to control cost. Let's bring 10 million lives, and let's look at the predictability model and see how many we're going to have, and then let's bring up a solution. It would be awesome if they could do that, or if HTA were to partner with a big coalition and work together and kind of come up with a solution, or pharma. I think those partnerships are going to have to develop to kind of get to the size and mass that we need in order to control the cost together, and then make the right judgments about what it really is in the population, right? We don't really know. It's a rolling of the dice right now. It's like, tomorrow, am I going to have one? Tomorrow, am I going to have one? That's not the right way to manage a plan.
So I got a two-part question here for you. First one is, if there was one action that an employer can take this year that would better protect their plan, what would that be?
It's kind of like A and B, right? One, get educated, know what's coming. And two, educate yourself about what's in your population so that you can have the conversation. There are companies out there that will do a predictive model. Your health plan will probably do a predictive model, maybe 80%, right? But I think you should do something to kind of like be knowledgeable about, one, the exposure you could have, and two, what's out there and what's coming. Because I think that's going to help prepare you. But I also think third, it's maybe a C, is kind of consider value-based benefit design. Put it in place for 26. You don't have to put it in place in cycle. You can do it off cycle. You can do it in April and really get good attention around it. But really put in a couple of value-based benefit designs that say, hey, if you do this, we'll give you free access to the drug, right? But if you do this, we'll discount your thing as long as you're in the therapy, right? I think when we do that kind of trade-off, it's better than saying, I'll give you $100.
Yeah, I think that's what you're saying around the value-based benefit design is a good one. We understand and appreciate that, but there's unfortunately a lot of people in the marketplace that don't really understand it, and particularly an off-cycle implementation. But that being said, let me give you a magic wand in your hand and ask you if you could make one change on how we manage this high risk care. So not just the high risk drug, but high risk care in employer sponsored plans, what would that be?
As an employee benefit expert, I am enamored that employers can handle this stuff. But this is not their core business, managing benefit plans. Most businesses do not manage benefit plans. And why are you in the core business of managing benefit plans? If I had a magic wand, we would not have employer healthcare coverage. We would have some kind of a national coverage. Everybody would be in the Affordable Care Act. Bring the risk pool together and bring that mass of 160 million lives to the 110 that are already in there. Now you have 270 million people in a risk pool. Do you know what that does to that risk pool? It diminishes it. And now all I have to pay as an employer is an HRA to you, and you go buy. And now you can buy in a marketplace that's probably better sustained and has a better risk pool across an insured product. And that would be the magic. It's almost like creating a national healthcare system without creating a national healthcare system. And I think it's the right answer because I don't know that employers can do this alone. And even if you're big, I tried it for many years at Walgreens. It is a challenge. And you're fighting a lot of things, internal decisions, internal machinations, internal relationships. They exist, right? If you're going to cut a benefit, but you have a relationship with a hospital and you're going to cut that hospital, you can't cut that hospital, even it's the best thing you can do. And so I think those trade-offs are hard as a business. They just shouldn't be there. And if I had a magic wand, it would be put everybody in one risk pool and have a good benefit plan that everybody could manage and pick the right one for themselves with a broker. And I just think it's the best. I'm not trying to push national health care. I just think that when you think about risk, the best way to manage risk is to have a pool that is distributed and equal and has more favorability toward the well. And then you stop managing illness, right? You manage for wellness. We're a sick healthcare system, not a healthcare system. And until we get away from being a sick healthcare system, so it's actually an A and a B, but my magic wand would be get us all together in one pool and get employers out of making these decisions that they should be making. And let's have everybody have a fairness of benefit every year, whether they are at one employer or another. Just seems to be a much better way to deal with this because I don't see a magic bullet. We've always been trying for magic bullets. We tried high deductible plans with HSAs. We tried dynamic copay. We've tried, which is surest. We've tried reference-based pricing. We've tried all this other stuff. We tried private exchanges for 5 years. Never works because you don't get the right distribution. You don't get the right risk pool. It just makes sense. And I'm not an actuary, and I think an actuary would tell you that's the right answer.
Well, this is a great place to end on, Tom, and thank you for your insight on this topic. Not a lot of people appreciate all the manifestations of risk that employers have to deal with in the positions that they're put into in the commercial insurance side. We talk a lot about Medicare, Medicaid. So this particular one really addresses some of the more urgent challenges that we see in benefit design today in the US in that commercial space. And the kind of summary points around employers have got to engage, they need to get educated, they need to have the knowledge is probably more true than ever in the work that we're all involved with right now. And then importantly, then do something. Once you have that knowledge, that has to happen.
That's the worst part, is doing something. You got to jump over the ledge before everybody else does. And you can't wait now. I think you need to move.
Thank you for tuning in to the Only Healthcare podcast. We hope you found today's episode insightful and informative. Remember, our mission is to provide actionable and inspirational insights on how we can improve healthcare cost, care, and accessibility for all. If you enjoyed this episode, please subscribe, rate, and share with your friends and family. For more resources and updates, visit us at onlyhealthcarepodcast.com. We'd love to hear from you. Let us know what topics you'd like us to discuss in future episodes. Until next time, stay informed, and together, let's navigate the journey to better healthcare.